Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Professor Lyndon Mason from Liverpool, United Kingdom. Professor Mason qualified from the University of Wales College of Medicine, completing his orthopedic training in Wales before moving to Liverpool as consultant specializing in major trauma and foot and ankle surgery. Before joining the Liverpool University Hospital NHS Foundation Trust, Professor Mason completed the Bofors Traveling Fellowships in the University of Utah, Salt Lake City, and the Carl Gustav Karras University, Dresden, Germany. In Liverpool, Professor Mason obtained the Bofors Gold Fellowship Award, and Professor Mason's pioneering research has become nationally and internationally recognized, winning 17 national and prizes in the last 8 years. He's been awarded the Hunterian Professorship from the Royal College of Surgeons in 2020 for his work on ankle fractures, the Robert Jones Gold Medal and the Association Prize in 2017 for his work on the evolution of the foot, and also the Jacques Dupart Prize from the eFoot for his work on discovery of a new foot ligament. Professor Mason has won the Chan Chen Memorial Prize, the highest award from the Bofors, on 3 separate occasions. Professor Mason is the honorary associate professor at the University of Liverpool and also sits on the council for the Bofors as the outcomes committee chair, taking responsibility for the National Foot and Ankle Registry. So today is my great honor to introduce you to Professor Lyndon Mason from Liverpool, United Kingdom. Over to you, Prof.
Thank you very much, Tesh, and thank you for the invite. Everyone knows me, knows I can speak at length for long periods of time on the posterior malleolar fractures. It has been a labor of love for the last almost 10 years, and I've done a huge amount of research into it. So my topic really is where are we in 2023, because it's very different to when I first started looking into posterior malleolar fractures, the journey not only we have had, but also other places around the world. So I do have some disclosures based on the research that both myself and one of my colleagues, Annie Malloy, did on ankle fractures. We become implant designers based on the posterior malleolar fractures for Orth Solutions. I'm also a consultant with other companies. There's a lot more than just this on my Foot and Ankle YouTube channel. And these are the QR codes for that, and also to follow on Twitter or LOTS Twitter. So first of all, where were we? So the historic results were poor. So prior to 2017, I termed this the time of the third. And this comes back from a paper back in the 1940s in the Journal of Surgery, Gynecology and Obstetrics. This paper was very unlikely to be published on today's standards. But this paper by Nelson and Jensen is where this third classical trimalleolar fracture comes from. There's also discussion, well, so you expect them to do badly as this is an articular injury, and presumably due to the articular injury, they would likely do worse. And 2 systematic reviews of the literature back in 2017 or prior to 2017 both reported poorer results in posterior malleolar fractures functional outcomes, and both noted the importance of articular step in the overall result. What they also noted was that the percentage of joint was not a factor. So this whole third business is something that I've been fighting against for the last 5 to 10 years. So how can we improve the outcomes? So our ultimate aim was to look for a stable anatomical reduction, including correction of any articular step, trying to get healing as quickly as possible to return to function. To do this, we need to know what the injury is, achieve anatomical reduction of the joint, achieve stability long enough to allow healing, and then promote early movement. But did we really know what the injury was? So prior to 2017, posterior malleolar fractures, the only paper really out there was the Haraguchi classification, and then the Bartonesek classification did come out in 2015, but it was not widely reported until after 2017. But these really are noted as different mechanisms. So you have the injuries such as the apple, which is a PITFL avulsion. It's a ligamentous injury with the ankle fracture. However, your orange and pears are articular injuries. This is due to either a rotational pilon, because the talus hits the back of the tibia and rotates it off like you would the medial malleolus, or the axial loaded pilon, where the entire posterior plafond goes in the same line as your fibula fracture. And this was the work that we initially did. So the classification that is now termed Mason and Malloy was back in our paper in 2017 in Foot and Ankle International. And to look at this more importantly, so the biomechanics papers prior to this only really looked at your x-axis translation, so your posterior loading of the plafond. But it's important to note that your posterior malleolus is also important in your z-axis rotation. So these are your different mechanisms. You've got PTFL avulsion, you have a rotational pilon, which is termed as a minor or a major, and then you have your axial loaded pilon. And it's your rotational pilons, which were primarily ignored, especially with this percentage of you didn't fix anything from 25 to 30%. These are the classifications. Our classification is very similar to Bartonesek, be it that we term the rotational pilon as a unique entity, a minor and major variant. Your type 1 PTFL avulsion is due to an unloaded talus. This can occur either in pronation or external pronation or supination injuries. As you can see that the foot is off the floor. As the foot rotates, this is the pronation type injury. You can see the small avulsion of the medial side. And you can see around the back, posterior inferior tibial fibula ligament pulls off this chunk of bone as the high fibula is damaged. You also expect an anterior syndesmotic injury. The small fragment you can see medially here is due to the intermalleolar ligament avulsion. The second type of injury, supination external rotation injury, can also be give you a similar appearance, but with a lower fibular fracture, where you may not get your anterior syndesmotic injury with it. You can see as it rotates around, you can still get a pull-off fracture due to the PTFL avulsion. This is what we term your type 1s. As you can see with these, is that your talus do not hit the posterior plafond. Your rotational pilons, your minor and major, your type 2 fractures. The foot is loaded, therefore the talus does hit. And usually supination injuries, it's the posterior plafond, the lateral aspect initially, as you can see by this schematic. And as it turns, the major aspect is if it then follow on and hits the posteromedial aspect. And this is the type of fracture planes that you get. What's important to note here is that your posteromedial, because the rotational nature of this pilon, sits under the posterolateral aspect, as you can see here on the type 2Bs. And because of this, because it sits underneath your posterolateral aspect, if you try to fix the posterolateral without fixing the posteromedial, we'll go into this more detail later, you can get a splitting out of the posteromedial side. Your type 3 is your true posterior pilon. So this is your foot, which is plantar flexed, axial loaded, and usually goes in the same direction as your fibular fracture, as you can see here. With these ones, you often get a avulsion type fracture of your medial side to give you a Y type medial malleolar fracture. And this is from Bartonesek's paper. You can see these posterior plafons, they're all in a similar type of nature. It involves the incisura. It sometimes doesn't go all the way along to the medial side, often just into your tibialis posterior sheath. So there was 3 biomechanical papers prior to 2017, all saying about this 25 to 30%. Unfortunately, these did not look at your Z-axis rotation. There's been one paper by Haraguchi since, which did look at your rotational nature, and these showed these type 1 type fractures. Another important to note, as this paper shows, that the less than 25% PM created in this biomechanical paper showed a significant problem with rotational instability. So this is why it's really important to note that these 25%, even though that the percentages are not really discussed anymore, can have these rotational pilons. This is one of our other papers that we look more in depth to your medial aspect And your medial aspects can have these small avulsion type nature due to the intermalleolar ligament. These do not necessarily need to be fixed. This is a secondary stabilizer. But it's important to note that these are not your true type 2Bs. Next thing, CT is required to know the injury. Now, this was a battle initially in my unit, but it's no longer the case. If you are dealing with these injuries without a CT scan, you often don't know what you're dealing with. So how reliable is a plain radiograph? There's 9 papers. Actually, there was another paper recently, so this is up to 10 now, all showing the same thing, that CT scans change the surgical management. Posteromedial fractures are not visualized, and the 22% diagnostic accuracy. So you wouldn't got a 1 in 5 chance of knowing what you're dealing with. So CT is very important. For example, as you can see here, we got a small flake off. We are unsure whether it's the impaction. This was a PATFL avulsion. This lateral X-ray, do you know if it's any different for the last one? Well, actually, this is a 2-part type 2B type fracture. Another one not too dissimilar to the initial 2. This is a type 3 fracture, very large posterior profound fracture. Again, another one you may identify 2 parts of this fracture. This is a large type 2B fracture. So you do not know what you're dealing with if you don't obtain a CT scan. The other thing is soft tissue entrapment. This is some of the work that my academic fellow has been doing recently, Junaid. And you can see here that we have the tibialis posterior within the fracture plane. So if we don't CT them and we are just doing a posterolateral incision, unbeknown, so then we can entrap this. We'll talk about this a little bit further later when I show some cases on this. But this is some work that he's been doing very recently. Shows that if your fracture line enters the tib post sheath, so into this area here, then you've got a 34% chance of a minor tendon entrapment and a 7% chance of a major tendon entrapment. So as we almost reaching 50% tendon entrapment with this, the number one, we need a CT scan to acknowledge this. We might need to alter our incisions to deal with this also. So one of my mentors, Prof. Pallister, these principles, you can be lucky and have a good plan executed poorly or a poor plan executed well, but you want to achieve really a good plan executed well. That's what we're looking for. And to this, we need to know what we're doing. We need to know what we see, and that's why CT required is important. The percentage of joint, I've already said, there's no correlation to outcome. As I've already said, less than 25% group in your rotational pilons and your PATFL avulsions. And these systematic reviews show that the size was not a factor. Also, a longer-term follow-up reduction is key. A particular step-off was an independent indicator, but size did not matter. Also, fracture morphology, not fragment size, dictated the functional outcomes. Not all PM fractures have syndesmosis injuries, but PM fixations help stabilize syndesmosis. This is something that's now being discussed a lot more, where people are fixing the posteromal and then saying, well, syndesmosis is definitely now intact. This is not always the case, and this is an important fact that we need to discuss. There are 5 papers indicating a reduced need for syndesmotic stabilization. The stability of PM fixation is much greater. However, some PM fractures don't have syndesmosis instability. Back in our paper in 2017, we showed this, that the larger the fracture fragments, like your type 3, the less the ligamentous injury. Some work on Wagstaff in our units has also shown this to be similar with your AITFL. It's the paper that we did in the cadaveric lab showing that your superficial PITFL extends all the way up the back of the tibia. So because you've got a rotational pilon doesn't mean your posterior syndesmosis is not stable. Showing comparison, your average size of your 2B fracture and the average size of your superficial PITFL is much greater. So it doesn't mean that your syndesmosis is unstable. Similarly, PM have persistent instability after PM fixation. So if you've got a high fibular fracture, it's very important to acknowledge this, not only the posterior aspect. So this is a type 1 fracture treated in a unit. The surgeon at the time felt that they were going to fix the posterior aspect of the syndesmosis by fixing this small fragment back to stabilize. So you can see in both the intra-op and post-op, the syndesmotic instability is maintained. And this is the CT scan comparing it to the other leg on this patient, showing this persistent widening of the syndesmosis because the other ligaments have not been addressed. To note that your posterior incisura, the fibula, posteriorly translates and then rotates. So it's important for that rotational stability. However, if you have not addressed the anterior aspect, it can still be rotationally unstable. This paper, biomechanical paper, showed this year exactly that in your high fibula fractures, if you just fix the posterior malleolar fracture, it did not necessarily fix the syndesmosis. Other factors, we need more than one approach. So this is a paper that we did on the clock face nature of these different fracture patterns, showing that your type 2A, yes, you can do a posterolateral incision and get to it very reasonably, but your type 2Bs and type 3s might need further medial approaches to further address these fractures. And this is just a schematic showing this, that your medial posteromedial can get to these type 2B fragments and your larger posteromal fragments. We've also done more cadaveric work looking at this, and your medial posteromedial approach allows much greater exposure to the fracture surface. And when you compare this to the size of each fracture, the medial posteromedial is much more likely to address the entire fracture. Your type 2A rotational pilons. So to show you this, this is a way that there's two ways to prepare for this. This is a full prone patient, and you can see the contralateral limb has been dropped to allow your lateral X-ray. But I do this very rarely now. My most common is the semi-prone recovery position, because the anesthetist is happy from the top end. The foot is still in the prone position, can get to the medial side a lot easier, and you can just bend the other leg out of the way to get your lateral. And for me, this is my go-to position for this now. Your posterolateral approach, we've done a paper on this showing this is the most used approach when it comes to posteromalleolar fractures. We talk about the 3 pops. So this is me, it's been drawn out on a cadaveric limb here. And then so if we join this, it's called the intermalleolar line, and then the line halfway in between your fibula and your tendon Achilles will give you your approach, was to note that your sural nerve runs from 7 centimeters from the intermalleolar to 7 millimeters below the fibula, and that's where you'll see it the entire time. So it's important to protect your sural nerve and saphenous vein. You open up the investing fascia, which is the first one, and then you'll get to the fascia over your flexor lucis longus and perineal compartments. It's important to open these up separately. If you open up these and go from one to the other, the perineal artery, which I'll show now, is likely to be damaged. This is your perineal artery. It's very variable. It attaches to your FHL and can be damaged if you go from one to the other. You'll then bring your FHL out of the way to get the periosteum. Now also, about the periosteum, there is a branch that goes from your posterior tibial artery to your perineal artery, and you'll find this is one that you'll have to sacrifice if you're doing this approach. And this is showing you a typical type 2A fracture. Your fibula then can be approached through the perineal sheath. As you can see, your artery here lies between your perineal and FHL. You can see there to be within the sheath, and then we open up the fibula from the back. If you've got a high fibula fracture or a very common fibula fracture, I would highly recommend not using the posterolateral approach. It's much easier to do a direct lateral and a posteromedial, and we'll come into that now. So this has been addressed, the posterior approach to the fibula, and you see a fixation of that posterior, a 2A posterolateral fragment. Your type 2B rotational pilon major. So you can see this is a very difficult fracture pattern. We have had the talus rotate and has hit off your posterolateral and posteromedial fragment. I'm going to avulsion the medial side and a high fibula. So doing a posterolateral approach to try and address this is virtually impossible. So we're looking to do a lateral approach and a medial posteromedial to get to all these fragments. And also we open to fix the posteromedial side first to stop it spitting out. The medial posteromedial approach, this is a go-to approach, and this is my workhorse approach for most of these now, for many reasons. You open up your tib post sheath, you open up your periosteum. You can either bring your tib post lateral or medial. I generally pull it medial and work between the interval between tib post and FDL. And then you open up the periosteum, and you can go all the way across the back of the tibia. You can see here is the tib post in view. As you bring the periosteal, you can see almost all the tibia. This is really the best approach to get to the much greater side apart from the posterolateral fragment. There's that fracture plane we showed earlier. We got this plate that was pushing down this posteromedial fragment. This screw is fixed in your posterolateral, and then we've got a fibula. As you notice that there's a syndesmotic screw because this does not stabilize the syndesmosis because it's a high fibula fracture. This is another fracture plane you can see here. This is sitting underneath your type 2A. And this is the plate for the type 2A fragment. This is the plate for the type 2B fragment. This has been done through this incision here. This is him at 6 months. The other thing about the medial posteromedial, you can extend this all the way up to the top because it's along the fasciotomy line. So this is the biggest posteromal fracture I've ever treated. And you can see I've been able to put a plate on much further up through a separate medial posteromedial incision, more superior to allow a correction of the apex. A type 3 true posterior pilon is like this, where you got the axial loaded in the plantar flexor foot. Posteromedial approach can be used for this and the medial posteromedial. If it's doing a posteromedial approach, this is go through the same interval deep as you would for the posterolateral approach, but your incision on the skin is more medial. So you just go next to the tender Achilles, you open up your FHL sheath, pull your FHL to protect your neurovascular bundle medially, and then you're in the same interval as you were through the posterolateral approach. So if you want to address the fibula through a lateral approach, that's as a high fibula or convoluted fibula, then this is the way to go for your 2A fragments. So this is that example. As you can see, this has been fixed through that approach quite easily. So fragment-specific fixation has improved outcomes. So this was our own paper. Back in 2014, we showed that those that we fixed in the old, you only fixed greater than 30%. We had a persistent functional scores very low. And then we published this in the JBJS America in 2019, showing through a fragment-specific fixation, our OMAS scores come up to the same level as you expect for unimalleolar fractures. We weren't alone. There's many papers out there now showing exactly the same level, 2 to 4 papers showing functional equivalence to bimalleolar or even unimalleolar fractures with fragment-specific fixation. The directed approach is superior to indirect, so a lot of people are used to just fixing it from the front. There's 3 papers on this, level 1, 2, and 4. Actually, I read another recent one, so there's another level 2 study, shows significant improvement in anatomical reduction and functional outcomes with direct approach. And this is the reason. So if you've got fragments like this, you can have an integrated fragment. You can have this screw hit and push off. You've got the soft tissue entrapment. To give you more example of soft tissue entrapment, this is a case that came to my unit. We'll talk about the safe zone on this. So this came from Spain. This was the initial CT scan. We decided to leave it in situ initially. But 6 months down the line, you can see that the entrapped tib post tendon has even formed its own sheath. We discussed already the fixing the posteromedial first. To give you an example of this, this is a case from quite a while ago. This screw is outside the safe zone, but also we have a push out, a double medial shadow, because the medial side has been spat out as the lateral side has been fixed. So this is a case not too dissimilar. We have a posteromedial fragment. You can see here, this is the CT scan showing this. So we want to fix this first before this side. This is what's happened. We've got the posteromedial fragment fixed with this plate and these 2 screws fixing the posterolateral fragment. And this is her a few months down the line doing very well. This is another case very similar. Here, this screw here is fixing the posteromedial before this is addressed with this plate for the other fragments. There's a safe zone. I've already noted this once or twice before, but there's a paper on this. So just to give you an example, if you've got anything lateral to this line here, then be cautious. This shows the screws within the incisura. And this is the line we're looking at. This is the Boston group has shown this. If this screw is lateral to this line here, this is your posterior incisura, then do be concerned. It's not always the case. This is one of my own cases, and this looks lateral, but as you can see on the CT scan, because these screws are going so medial, then the insertion points was okay. But please be of note to say so. The last thing was unanswered at the moment. This is what a lot of research is going into, is what do we do with the die punch fragment? So with the die punch fragment, there's two papers looking at this, showing a worse outcome if they have a die punch. This is from a paper back in JBS America, where we've gone back and looked at the die punch versus the non-die punch. There was significant, again, OMAS scores have dropped if they have a die punch. And what the problems with this? Well, you can't see the joint, can't see the incisura. Radiology has limited use, so you have to be a lot more aware of how we're going to get into the fragments. So this is one you can see here. We've got a die punch fragment, comminution at the back, and this is the large posteromedial die punch. This is what we have to get to and try and reduce if we can. And this shows the medial posteromedial is a very good approach for this. You can approach and open up this book to get into any die punches at the back. So this is the fracture that we have. This is where the die punch was. It's now back into normal level and it's been fixed in situ. So another one where you can see like so a lot of comminution in the back here. You can see this is where all the die punch and the fragments are. You can see that this is what we have to deal with by coming through the medial posteromedial. You can get to all these fragments here to try and reduce it. This is showing this. As you can see that the sheath of where your tib post, and you open up that periosteum, and this is where your fragments are. So it's very easy to approach the medial posteromedial. And this is that same patient. We can see that we got a constitution of that joint line in the back here now, where the fragments were. This is another case, but where you can't come through the medial posteromedial. So this was already healed, but had this lateral die punch fragment. For these, then we can get through it through the fibula. So you can do a large fibula incisions and rotate the fibula out of its sheath to get to this fragment. This one didn't require the rest, and this was a osteotome placed through the fibula to allow its reduction. As you can see, we got this down to level before fixing. So there we go. This is what we know in 2023. This is a huge amount of work that has been done, not only in our unit, but around the world, as people have come to acknowledge that these fractures need to have a more fragment-specific fixation, and it's not something that we need to ignore. Percentages should no longer be discussed. Thank you very much.
Thank you, Lyndon. Lyndon, you can stop sharing actually.
Yeah.
Thank you, Lyndon, for this amazing presentation, and congratulations for the fantastic research on posterior malleolars that you've been doing, and you've been presenting it all over the world.
Yeah, thank you very much. Thank you for allowing us to do it here as well.
Lyndon, just a couple of questions. Lyndon, what do you think is the utility of a posterolateral approach for a pilon fracture? Suppose you have a large posterior fragment in a standard pilon. Do you think it's a useful approach?
I think the posterolateral approach is very, very overutilized. It is. I have not used the posterolateral approach in my practice now for about 18 months. You can only get to a very small aspect of your back your tibia, and your fibula. Trying to fix your fibula from the back, if it's not a simple oblique fracture, is very, very difficult. So the medial posteromedial now has become my workhorse approach. So if you're fixing pilon fractures, not only ankle fractures but pilon fractures, it's still my workhorse approach, because you can get to it very easily. You can put a plate medially, you can put a plate posteriorly, and you can ensure that your tib post is not encased within the bone. So no, the medial posteromedial is now my workhorse. Yeah,
thank you for that. And Lyndon, I think around a few years ago, around a decade ago, there was a hype in the posterolateral approach, and everyone started doing the posterolateral, right? And over a period of years, I think the posteromedial allows more exposure and allows more, visualization, isn't it?
Yeah, No, 100%. It's one of those ones where where people are not confident doing the approaches, but then when you've done it once or twice, you go, yeah, that's all. I can see everything, and it only takes a bit of confidence. So I've been running a few cadaveric courses recently, and one of the biggest factors on it is the medial posteromedial approach. And when people have used it, so they will be very confident of using that going forward.
And what is your position? For example, if you're going post-lateral, what is your position? Do you do the sloppy lateral, and then if required, you can bring it to supine? And what is the approach for, I mean, what is the position for posteromedial as well?
So the recovery position is my go-to position for almost all back of the ankle approaches nowadays. Do you need to flip them supine? No is the answer. I've never had to. People are sometimes concerned with the medial side, that you can't quite get to it. But if you're in a recovery position, you've got a lot more rotation in the hip to allow you to rotate it to almost lateral to get to the medial side. So the recovery position is a lot easier than the prone position for that, and also the knee twist is happier. So yeah, I've been through all these learning curves. I've started with one thing and moved to another. I'm very comfortable with what I use and the things I use nowadays. But the recovery position is a game changer, really. You start using it and realize it's very, very easy to use.
Thank you, Lyndon. Just one last question before we wind up the session. Lyndon, we have readers from around the world, and someone posted me a question: whether are we still able to do an AP fixation, anteroposterior screw fixation, like we used to do? I mean, it was postulated years ago that a lot of people use the front to back fixation, right? Indirect fixation. Is it still relevant today?
So there's a number of caveats to that. First is, if you are able to see your reduction, then yeah, of course you can fix it front to back. So for example, if you're doing a fibula turn down to note your reduction, then fixing it front to back, then yes, you can see it. If there was on Twitter, there's a few of the Americans have got CT scan in theatre, and great, you can see your reduction. And if you do an arthroscopic fixation, that you're scoping them, you can see you've pulled the reduction, you've got the fixation, then yeah, and so an AP screw is fine. But you need to ensure that you got reduction. If you're going to rely on imaging, then no. So I don't think that it is a lot of luck and crossing your fingers and using the force involved there. So I don't. For me personally, there's a lot of papers out there showing that it is worse with the reduction. So unless you can ensure reduction by all the different factors, then no. Let's try and use the direct approach.
Thank you, Lyndon. I think that's all the questions that we have for this session. Thank you, Lyndon, for this fantastic presentation. I'm sure it's going to benefit a lot of people.
Fantastic. Thank you very much.
And look forward for one more in the future.